I would like to welcome all of you to our town hall meeting on getting Michigan dentistry back to work. I am Dr. Margaret Gingrich, your current MDA president. I have a private general solo practice in Big Rapids, Michigan. We will be giving you an overview of what has happened over the last few weeks with the emergence of COVID-19 in Michigan. Please note the chat box has been disabled and all comments and questions should be entered into the Q&A box. We will try to answer as many questions or topics as possible during this town hall. But please be aware, due to time, we may not be able to answer all of your questions. I know you have all been following the news, but here is some current statistics on COVID-19. The CDC reports that there are almost 1.4 million cases of COVID-19 and over 84,000 deaths. Unfortunately, Michigan has been a hot spot, but it appears that we have flattened the curve. We want to bring you all up to date on what the MDA has been doing to address the pandemic. The agenda is before you and what we will be covering today. As you can see, we are not going into the mechanics of actually reopening your practice. There are many resources available, including the MDA website and the ADA website for that. We hope to be addressing some of the key points related to practices and reopening post-COVID. Joining us today as panelists for the town hall are MDA legal counsel Dan Schulte, our Vice President of Advocacy and Professional Affairs, Bill Sullivan, MDA Editor, Dr. Chris Smiley, one of our current trustees, Dr. Vince Benevenia, Michael Wilgus from our dental supply partner, TDSC, MDA past President, Dr. Deborah Peters, and President-elect, Dr. Steve Murrah. And last, we have Karen Burgess, our Executive Director, who will moderate the question and answer section. Dr. Smiley, Benevenia, and Murrah, and myself all served on the MDA task force on reopening dental practices. Now on to key dates from COVID-19. Before you is a summary of COVID-19 dates. I would like to review some of the dates since the start of the pandemic. It may seem like a very long time ago, but members were clamoring for guidance and requesting the MDA to weigh in and advise them on what to do to protect their patients and staff. On March 16th, the MDA requested delaying non-emergent care. We stressed dentists to stay open for urgent and emergency treatment to keep patients out of the ER. Later that same day, the ADA had the same request, and 4 days later, Governor Whitmer issued the Executive Order 2020-17. The MDA actually issued guidance to our members to delay any non-emergency care before the governor required us to do so. We believe the public health and safety, the safety of our dental teams, were needed to flatten the curve, and the preservation of already scarce PPE was the right thing to do. Later on, the question came up, do we need to match the ADA or the governor? After discussion, the board supported the idea that dentistry should limit care to emergencies and follow the executive order that limited care while the emergency declaration was enforced. We are aware that dentistry would need to be decoupled from the state of emergency declaration at some point in the future. Within just a few weeks, we realized that this pandemic could go on for a very long time, and it was not feasible for dentistry to remain shuttered indefinitely. How to reopen was the question. So I established a task force to address the questions and give guidelines to dentists on how to safely reopen their practices. At the same time, we knew that the ADA had a similar task force, and we were able to share some information. This was very helpful for our task force to have a starting point and make recommendations specific to Michigan dentists. We could see that how to open would soon become clear, the board voted on April 23rd to seek the decoupling of dentistry shutdown from the emergency declaration. On April 27th, the ADA came out with its toolkit, and we thought it was a good resource and wanted to add to it. Just 1 week later, we published the Michigan Addendum. This included information specific to Michigan dentists and more resources for our members. The same day, we went to the governor and provided this information she had requested and said, here is how we can reopen safely. She promised to use our recommendations in her planning, but no timeline was given. At the same time, the MDA had been collaborating with our healthcare providers. If we did not hear from the governor in 1 week, this coalition planned to make a united front to ask for the opening of all healthcare. Please note that each profession has developed plans just like our addendum and toolkit, like the MDA, and has asked Governor Whitmer to open up. Just yesterday, the coalition urged the governor to take action today. We believe that we have a very good chance of success because our approach is reasonable and addresses every concern the governor may have. We also believe if dentistry is opened in our state, we may have more access to available PPE. I'd like to note that the board took this whole process very seriously and was meeting weekly. It is a very challenging time, and I'm aware that we have some members who cannot wait to reopen, while others are very cautious. When dentistry does reopen, it will be critical for all dentists to plan very carefully, work with their teams, and educate their patients. It is not required every dentist open at the same time. The MDA wants the ability for our members to decide when is the best time for them to open up. We have spent the last 10 weeks helping you prepare, so I'd like to take just a couple of minutes to highlight these activities also. Keeping dentists up to date. Nobody wants me to read out the slide, as you can see, I'm sure. Just to point out that Michigan dentists, both members and non-members, from whom we have email addresses, have received a total of 23 special alerts related to COVID-19. You may wonder why we included non-members. There are two reasons. First, this is a professional issue that strongly impacts the public health, so we have a duty to try to inform all Michigan dentists. Secondly, we recognize that if we were helpful during this crisis, non-members would be more likely to see the value of membership and decide to join. These alerts keep you up to date on what is going on and the highlighted new MDA and ADA resources. Readership of these e-alerts was high for electronic communications. The open rate was over 50%. Still, that means that almost half of these recipients were deleting without reading. Interestingly, non-members were just as likely to open as members. Now on to our free webinars. We have also been doing a series of free webinars. Again, members, non-members, and staff could participate. Our first one, just a few days into the pandemic, set a new record with over 1,300 participants at the live webinar. Many more viewed the archived version. There will be more webinars coming in May and June. Please read your MDA e-alerts for more information on these. Now on to our PR and media outreach. On Wednesday, we sent out an e-alert that brought you up to date on the MDA strategy when it comes to media outreach and also educating the public. This slide is just a reminder of the large number of newspaper, TV, and radio coverage that the MDA has initiated over the last few weeks. This is continuing. Just yesterday, I interviewed that ran on WNEM in Saginaw, which laid out our case for reopening dentistry, a very positive message for all Michigan dentists and patients. Throughout the pandemic, we have been helping educate patients about what is emergency care, how to reach out to their dentist, and for people who do not have a dental home, where to seek care when they need it. This is my update for you on the MDA activities. After we get through all of the presenters, I will return to answer some of the more detailed questions that have been asked. Now, I'd like to turn it over to Dan Schulte, who will address the executive orders and the effect of dentistry and answers some of the most common questions. Dan?
Thank you, Dr. Gingrich. Executive Order 2020-17 imposes restrictions on non-essential medical and dental procedures. It went into effect on March the 20th and will remain in effect until there is no longer a state of emergency in effect, it is rescinded by the governor, or there is a court order to the contrary. To date, only a single FAQ has been issued regarding this executive order. The only other guidance that has been issued on Executive Order 2020-17 was a May 3rd letter addressed to Michigan clinicians from the state's chief medical executive. I agree that additional guidance would have been helpful to clarify the meaning of this executive order. However, reading Executive Order 2020-17 and the May 3rd letter together as a whole, I believe that determining what dental procedures may be provided currently requires a two-step analysis that must be conducted by dentists using their professional judgment on a case-by-case basis. First, determine whether the procedure is required to be postponed by Section 3 of Executive Order 2020-17. These procedures which must be postponed are all cosmetic and aesthetic procedures, including veneers, teeth bleaching, or cosmetic bonding, routine hygiene, orthodontic procedures that do not relieve pain or infection, do not restore oral function, or are not trauma related. Initiation of crowns, bridges, or dentures that do not relieve pain or infection, do not restore oral function, or are not trauma related. Periodontal plastic surgery, extractions of asymptomatic non-carious teeth, and recall appointments for periodontically healthy patients. Second, determine whether the procedure is necessary to address an emergency, is trauma related where postponement would significantly impact the health, safety, or welfare of the patient, or is necessary to avoid a significant decline in health that would result from delay. If so, the procedure can be legally performed. If not, the procedure cannot be performed legally. Many have focused exclusively on the language in the executive order, stating that procedures may be provided if they are necessary to preserve the health and safety of the patient, and have argued that this alone is the standard to be applied. I think this is mistaken because it ignores the specific prohibition on certain procedures in Section 3, many of which can be argued to ultimately be necessary to maintain a patient's health and safety, and the other language in the executive order and the May 3rd letter indicating that to be permissible, a procedure must be in response to an emergency, trauma, or must be necessary to prevent a significant and imminent decline in health. In addition to being a misdemeanor, the governor directed the Department of Licensing and Regulatory Affairs in Executive Order 2020-17 to issue orders and directives pursuant to law as necessary to enforce the executive order. This means that in addition to other things, violators may have action taken against their license. Another executive order, 2020-30, generally provides immunity to all healthcare workers providing services in support of the state's response to the COVID-19 pandemic. They are immune from civil liability, including malpractice, unless the provider committed gross negligence. This immunity would apply to dentists providing care to COVID-19 patients in a medical setting on a volunteer basis or otherwise, but would not apply to providing dental care in a dental office. There is a bill currently pending in the legislature that would codify this immunity in a statute so that it would not end with the state of emergency and extend the immunity to claims allegedly caused by decisions to postpone treatment or other care. Testimony was taken at a hearing on this bill 2 days ago. MDA will keep you posted as it progresses. Finally, many have asked if there is liability risk in opening their office under the present conditions, and there certainly is. When opening their offices, dentists will be subject to new claims from patients and employees who become infected, alleging the infection was the result of coming back to work, and will have new risks of disability discrimination claims from employees that cannot wear the required protective gear and are refused accommodations. Whether these claims will be successful will depend on many factors, including your work rules, how they are applied, proof of the source of the infection, the plaintiff's contributory negligence, damages, and so on. To minimize the risk, dentists should not reopen without a well thought out plan for doing so. You will be hearing more about this from Dr. Smiley shortly. For further assistance, I would recommend the ADA's guidance and the MDA's addendum to that guidance. Thank you for the opportunity to speak to you today. I'll now turn it over to Bill Sullivan to discuss the role of the legislature and the Michigan Department of Health and Human Services in this process.
I think when it comes to the whole area of state government right now, it's very important to understand that the governor holds all the power right now. She's basically been governing by executive order, and consultation with the legislature has been minimal at best. This has resulted in a very bad relationship between the legislature and the governor. The Republicans control the legislature, and as a result, there's not a lot of cooperation going on between the two. The legislature, however, is pushing back against the governor and is currently suing her. That case is in court, and the oral arguments actually took place today. The case is being heard in the Court of Claims, and it's in front of Judge Cynthia Stevens. The oral arguments are supposed to wrap up today, and Judge Stevens has said to expect her opinion sometime after Tuesday of next week. Basically, what the lawsuit that the legislature filed against the governor is that she doesn't have the authority to continue to issue executive orders without legislative input. One of the strategies that the MDA has been following because of the poor relationship between the governor and legislative Republicans is to work with the governor's allies in the legislature in order to get them to advocate to the governor for the reopening of dentistry. Just recently, we had a meeting with Senator Jim Ananich, who's the Democratic leader in the Senate, and he was very supportive of our position and said he will advocate to the governor that she allow dentists to reopen their offices. In addition to people that we've been meeting with in the legislature, we've also been working closely with the state's oral health director. That's Chris Farrell. She was actually part of the task force that the MDA put together to come up with its guidance for dental offices. We're just not sure how much the governor is consulting with the state's oral health director at this point. We are hoping that she is, but we don't know that for sure. There have also been several questions from people regarding the Board of Dentistry and what role that they are having in this whole process. And to date, they have had very little input. The reason for that is something that existed even prior to the whole COVID issue. The governor doesn't really give the Board of Dentistry any type of real regulatory authority. That has to come from the executive branch. The Board of Dentistry serves as more of a disciplinary body right now. As a result, the governor has not been consulting them. And I know that has been frustrating to several of the dentists who serve on the Board of Dentistry. One of the big problems that we faced from a governmental perspective in dealing with this whole issue with the governor's executive orders and when she is going to lift this and allow dentists to go back to work is it's not entirely clear what metrics the governor is using to decide whether to reopen. We're not the only profession that's having this problem. As evidenced by the letter that was sent to the governor yesterday, a lot of the health providers are having the same issue we are having, and other professions outside of the health profession are having the same type of issues. It's just not clear what metrics she's looking at when she's deciding whether to allow someone to reopen or not. Another question I wanted to address that came up from a lot of people is how can the average member participate? And the simple answer to that question is to respond to the action alerts that the MDA is sending out to you. That is where we can have an impact. There is an impact with numbers. And if a lot of people respond, that will get the governor's attention. And the one that we sent out yesterday dealing with this specific issue of dental offices being able to reopen, the response has not been very good to date. And the reason I know this is because we compared it to the last action alert that we sent out a couple of weeks ago regarding the financial relief package that was going through the Congress. At the same point and we are today compared to the last action alert, it's about 50% less. So we really, really need people to respond to that action alert. And the other part of that's very critical is we put in there the ability for dentists to tell the governor specific cases they're dealing with and give examples of how this is impacting your patients. That's another very important part of this whole process, but we've got to get more people to participate than what we currently have right now. So with that, I will now turn it over to Dr. Chris Smiley to discuss the reopening of dental offices.
Thank you. And hello, everybody. I've been asked to discuss the efforts of the MDA task force, its scope and work product. Now, the task force was comprised of content experts that included infectious disease specialists from the University of Michigan School of Medicine. We also had the infection prevention and compliance officer from the University of Michigan School of Dentistry, the chair of the University of Detroit Mercy's Oral Health Integration Department, the state oral health director, an infection control consultant who works with the Organization for Safety, Asepsis, and Prevention, and also with the CDC, a state board of dentistry representative, and practicing dental specialists and general dentists. We were charged with development of a Michigan-specific supplement to the ADA Return to Work Interim Guidance Tool, or Guidance Toolkit. The addendum posted on the MDA website is to be considered part of a greater ADA master document and not a standalone document. So, the question, when should we bring our staff back? Bring your staff back when it makes sound business sense to have them return. Now, safety is the central issue in addressing the needs of both your patients and your team. Do you have sufficient PPE? Are your systems in place to address ADA, CDC, and OSHA guidance? And obviously, have all the applicable executive orders been lifted? Consider bringing your team back, however, to discuss system development and review guidance, starting with the ADA's return to work interim guidance tool and that of the MDA's task force. But how can we assure that our staff is safe to return to work? A standard consideration for, I don't know if that second slide is up or not, a standard consideration for the MDA task force was for dental offices to be as safe as possible for our patients and our team. Safety begins with professional judgment. Following CDC, OSHA, and ADA guidance is a good place to start. Follow best practices for asepsis, performing screenings of patients and the entire team, and use of appropriate PPE and social distancing strategies. You must take a deep dive into these issues. Study and refer to your trusted resources. Review guidelines and tailor an implementation plan for systems to address your individual needs. Now, when we take a look at the ADA document being the master document, for example, the MDA chose not to amplify on the ADA toolkit recommendation that the use of pre-rinses should be done at professional judgment of the practitioner. So in the ADA's chairside toolkit, the second to the last bullet point states that no documented evidence exists at this time to support pre-procedural rinse to reduce the transmission of COVID. If you want to use it in your office protocol, that's your judgment, but we did not amplify on that. Now, some say it can't hurt, so you might as well use it. While others say it tastes bad, so it must be working. But these are not evidence-based arguments. There was a study from Western China discussing the use of pre-rinse for dental care, where the use of pre-rinses are a long-standing tradition in Chinese dental health care. Those who want to exceed the ADA or CDC guidance for addressing COVID-19 transmission during dental care may consider an oxidizing rinse, such as 1.5% hydrogen peroxide. And that's simply compounded in your office. You take the 3% over-the-counter hydrogen peroxide and you dilute it 50-50 with water. Or you can use a Listerine's whitening rinse. But you have the patients use these for about 1 minute, and then afterwards proceed with care. Longer appointments, you may choose to take off the dental dam and then have them use it again. Now, the ADA and CDC guidance should be considered best evidence. This is akin to using your evidence-based dentistry tools that we've been discussing so much in the journal. As we did not supersede in the MDA toolkit the guidance of the ADA or the CDC, but chose to provide clarification or Michigan-specific considerations. For example, you'll see in Appendix A welcome letter that conforms to the Michigan Department of Health and Human Services standards. You'll also see clarification on risks associated for the use of acceptable alternative PPE, as we see in this slide here. We wanted to clarify that PPE is an inclusive mitigation strategy that involves multiple factors. If a surgical mask is used rather than an N95, then a face shield and goggles or glasses should be used. If a face shield is not used with a surgical mask, that places the user at much higher risk for transmission. Now, we also provided Appendix E that addresses strategies beyond those found in CDC guidance. So let's go to that next slide. Things such as air filtration systems, UV light, and other options that may not be appropriate for all practitioners, and they are not part of the current guidance found from the ADA or the CDC. For instance, here we see an air filtration sucking device, and we also see a program that you can look at accessing for creating a gasket to adapt your surgical mask and create a seal. Other things including UV light. These products are being sold to our members, but they're not part of the guidance and they are not required. These suggestions that we have say that they are out there for consideration, but issues like UV light are issues that, depending on the intensity of the light, the distance of the source from the ambient aerosol, all decrease perhaps their effectiveness, and it's not known exactly what is achieved by doing so. Coupled with the fact that it can take your operatory offline for anywhere from 30 to 90 minutes may not be appropriate for you. Also, what you might want to consider is this app that you see there where you can take a facial scan of your face and you have a gasket that you fit over your surgical mask, and that provides a seal. I want you to understand that use of this does not raise your surgical mask to the level of an N95. It's still a level 3 mask or perhaps a level 2. But I don't want you to assume that that is somehow getting your surgical mask to the level that it is not. Now, a couple other questions that I wanted to address in here that we seem to receive quite frequently at the ADA. One of them deals with fit testing of a mask. Am I required to get a fit test? The MDA and the ADA recommend medical clearance along with fit tests if an N95 is going to be worn, as noted in the ADA guidance. Now, N95 fit testing is only required if wearing an N95 mask is required. It should be noted that OSHA has not required N95 masks for dental professionals unless they are treating known or suspected COVID positive patients. And this is determined during your screening session. And then the dentist also can require an N95 if the dentist's own airborne hazard assessment reveals the need for N95 masks. Now, logically, if you're wearing an N95 mask, a fit test and medical clearance may be advisable. Logically, this may be difficult also, logistically, this also may be difficult to achieve. But we recommend reaching out to local health systems, occupational health departments, and see if they can provide this service or recommend someone in your area who can. Also note, relative to creating your airborne pathogens risk assessment for your office. The ADA is posting a template for dentists to use in performing an airborne pathogen hazard assessment for your practice. The risk assessment can also be found on OSHA's webpage. And I'm just taking a look here, apologize for this, but I want to find, I think we had another question that related to the tracking of infections and deaths that are related to dental providers. Sadly, in Michigan, the Michigan dental community has lost a couple of our colleagues, Dr. Chris Furlet and Dr. Mark Marunchek, who were dentists in the southeast side of Michigan. Dr. Furlet was Dr. Furlet was completing his oral surgery residency, and Dr. Marunchek was a prosthodontist from the University of Michigan and also Wayne State University's medical school. Both of them provided care in medical setting. Now, the ADA is certainly interested in COVID occupational data too. The ADA's Health Policy Institute team has been putting out requests for official data on occupational statistics that are being done by government entities, as well as those seeking out alternative sources. Testing, public health surveillance, and contact tracing remain an issue and are the purview of the state health departments and public health officials. As state open up to dental care, we'll probably be hearing more about reporting on these issues. So with that, I will hand it over to Vince.
Well, hey, good afternoon. I'm Vince Benavenia. I'm an oral surgeon in East Lansing, and I'm one of your 9 board of dentistry. I'm one of your board of trustees, and I was on the MDA task force that came up with the MDA addendum to the ADA toolkit. And today I'm charged with talking about COVID-19 testing. So currently, neither the ADA nor the MDA recommends screening testing for COVID-19 for patients in your office or your staff. So that's the party line. There is a place for testing, and it would be for symptomatic patients, and you should probably refer those to your patient's primary care physician to have them do it, because if they turn up positive, then they're going to have to follow them and treat them, et cetera, and that's kind of out of our scope. So what's the status of testing currently in Michigan is that testing by dentists is allowed legally by Michigan. At the time our task force convened, the Board of Dentistry had an opinion that it was beyond the scope of dentists to test for COVID-19. However, your MDA board advocated for dentists, our member dentists, and Bill Sullivan and Josh Pluzak, our lobbyists, went to Lara and with the question of, how come we can't test? Why isn't it legal? Why is it beyond our scope? And Lara determined that it is legal and within our scope to do screening testing for COVID-19, and they overruled the Board of Dentistry's opinion on that. So currently it is legal if you want to do testing in your office. But so the ADA guideline in their ADA toolkit on page 10 and the MDA guideline regarding testing in Appendix E of the addendum to the ADA toolkit both recommend against testing. Specifically, the ADA says regarding coronavirus diagnostic tests, at this time, there is not an FDA-approved test that is widely available. There are a large number of gray market tests being marketed, not all with reliable results. Refer to the ADA news article, and then they cite an article that you can click on. It's hyperlinked in the toolkit that urges dentists to be cautious about using novel coronavirus diagnostic tests before they have been properly evaluated and made available for dentists. Then there's an FDA link that you can go to and read more about available testing. And then the last bullet point that the ADA says regarding testing is that for testing, see the list of state and territorial health department websites, which is hyperlinked for your specific area's information. So that's to send somebody for a test. That's the ADA guideline or recommendation from the toolkit. The MDA addendum says in Appendix E, the Centers for Disease Control and Prevention, CDC, American Dental Association, and other agencies will update information on evolving regulations, guidelines, and technology related to these recommendations. Members are encouraged to monitor evolving evidence and check back regularly to ada.org/virus for information on testing, environmental and mechanical mitigation strategies. So that's kind of what's written in the party line about testing in as far as the ADA and the MDA is concerned. The reasons that the ADA and the MDA have recommended against COVID-19 testing are many, and basically come down to problems with reliability, logistics, and costs. Now, COVID-19 testing, you can split into two broad categories. There are antibody tests, which show if you were exposed to COVID-19 and are recovered from it and have antibodies towards the virus. So you can get tested for that if you think you had COVID. And if you have a positive test, it doesn't guarantee immunity. So we don't exactly know what that means. In other words, you could be able to contract the virus again, even if you do have the antibodies. So we don't see much valuable in antibody testing for your patients or your staff. Then the other category of COVID-19 tests fall into the molecular tests, and they are basically antigen tests, which show if you're actively infected. But the in-office tests are very unreliable with reported false negative rates of 20 to 50%. Yesterday, there was an article in the Wall Street Journal, which looked at a NYU study that looked at the new Abbott test that is becoming available. It's that little unit that is basically a little desktop unit that you've seen on a lot of the news, and President Trump has been talking about it early on. Well, that test, the Abbott test, was shown to have a 48% false negative rate against a larger lab test when compared. So they're still not ready for prime time. The large lab molecular tests are better with high reliability, but they take hours to days to read. And during that time, when you're waiting, a patient could theoretically convert to COVID positive and become contagious, but still show negative on the original test that they took hours or days before. So that's a problem and would give you a false sense of security. Testing is also very technique sensitive, especially the nasopharyngeal testing, where they have to get that swab way in the back of your nose and almost down your throat. Not everybody likes it too much. And those tests are super highly sensitive to the technique, and that's what is believed to make a lot of these tests having a high false negative rate. Saliva tests are currently being developed and do show some promise, that maybe we could do down the line in our office, but they're not mainstream yet. So if you decide after digesting all this information that you want to test, probably the best way to test right now is to form some type of agreement or alliance with a lab or a local lab or a medical office to do the testing for you. But again, consider the time required to get back the results and possibly of the patient you just tested becoming contagious in the meantime. You can do, currently I mentioned you can do in-office testing. So if you want to make the dive and purchase a testing unit for your office, you can get a CLIA waiver. This allows you to do testing in your office and be all legal. But again, these machines are costly, they're technique sensitive, and have a very high false negative rate, especially the new Abbott test that's being done. So the bottom line is that COVID-19 screening tests ordered or administered by dentists is not recommended by the ADA or MDA currently because of those reasons. Thank you.
Thank you, Dr. Benavina. My name is Michael Wilgus. I'm the Director of Strategic Relations for TDSC, and wanted to take a few minutes today to give you some insight into what's obviously a very, very challenging PPE landscape in the dental supply industry. There has been some progress made in just the last week or so in getting dentistry sort of moved up the list with regards to FEMA. I think we were number 7 on that list, and thanks to some collaborative lobbying within organized dentistry, with some of the supply companies and even manufacturers, dentistry has been bumped up to 4th. But with that said, we're still not seeing any appreciable change in the PPE landscape. So wanted to give you some insight into what we are doing as TDSC. A lot of the things that I'm showing you today, are probably not unique to TDSC. I know several other supply companies are doing similar things to try to obtain the PPE that you need to go back to work. A lot of the manufacturers right now are under the Defense Protection Act when it comes to PPE products. So they are under direct orders to fulfill the government orders first. We don't have any insight into what levels the government is ordering at or what levels the government's trying to build up their safety stock. We assume it's going to be much higher than it was before the pandemic. And a lot of the manufacturers can't give us an ETA on orders that we've placed as far back as the end of February and early March. To that note, many of the manufacturers have stopped taking orders from supply companies. For those that are continuing to take orders, we place maximum orders as often as they will allow us to. And when we do see some inventory trickle into our distribution centers, it's at a fraction of what we've ordered. And typically those products are going directly to back orders that we have on hold for members that have tried to purchase those products. We're also searching for new sources of PPE, and the FDA and the CDC have lists of approved vendors that provide products in those spaces. So we are reaching out, and you can see, if we go back to the previous slide, some of the items that we're going after specifically. This is not an exhaustive list. We are seeing some progress in some of these categories, like face shields. There's been a lot of domestic companies that have stepped up and really fulfilled a need in this niche. Their models are evolving very quickly to accommodate things like loops, accommodate some of the bulky designs with the N95 and KN95 masks. We've got about 10,000 of these coming into our warehouse this week, and other suppliers are seeing similar success in that area. We're also seeing some movement in infrared thermometers and hand sanitizers. So we're starting to see inventory start to come back in some appreciable quantities, not the amount that we're ordering, but it's looking better as the weeks go forward. We continue to see significant challenges with regards to, level 2, 3 masks, N95s. KN95s are a distinct challenge in themselves. The FDA has an approved list of KN95 manufacturers that up until last week had about 60 different companies on that list. It has now been reduced down to 14 because many of those masks, once they were tested in the US and our labs here, did not pass the filtration tests. I'll talk a little bit more about that in just a moment. And isolation gowns continue to be a high area of focus, as a lot of the raw materials required in the mask manufacturing, as well as the skilled workers, are in short supply. They've been shifted towards the masks to fulfill the government orders over there. So we continue to focus on finding new sources for those. But outside of these traditional sources, if we go to the next slide, the other thing that we've been doing is vetting out a lot of leads. To date, we've vetted out about 275 leads that have come from all over. We're getting information from member dentists. We're getting leads from volunteer leaders within associations, and then a lot of leads are coming in unsolicited through our customer service line and through various other channels within organized dentistry. There is a lot of gray and black market activity out there, and so in order to sort of cut through a lot of that noise, we had to put together a checklist, and you can see a 10-point checklist here that we use just as a first pass to try to reduce some of the obvious gray and black market offers that we're seeing. Aside from some of the boilerplate stuff like a manufacturer name and manufacturer product numbers, we're looking for a paper trail that really starts with the FDA registration letter and goes on to continue on through clearance and approval letters. And we're looking for continuity of information there. We want to see the same manufacturer names, the same addresses, the same registration numbers, same product numbers. And this has proven to be a big hang-up for a lot of those people out there that are acting as brokers and claim to have information or access to large supplies of masks that simply don't exist or simply aren't coming directly from legitimate manufacturers. I want to talk a little bit about item number 3 here really quick. The FDA registration letter is something that we're seeing become more visible. And any company out there can register with the FDA as long as they fill out the proper form and pay the proper fee. That does not mean that they are approved or cleared. And I bring this up because we are starting to see masks for sale through supply companies, specifically KN95s, that are advertising FDA registered or FDA pre-approved. What that really means is not FDA approved. So be careful if you see offers that talk about FDA registered. That doesn't mean a whole lot. We need to see approval letters that they've been approved for emergency use or they've been FDA cleared. We always look for things like samples and photos. These are things that help us identify counterfeit goods pretty quickly. You know, we see a lot of broker activity where people are requiring huge minimum quantities. They want to know what price we're willing to pay, or they've got really, really high prices. We see price gouging a lot. And then payment information where they want us to put large sums of money in an escrow account before we even see the product. Those are all typically red flags for us, and we would not participate in relationships that involve those types of things. If we go to the next slide, I wanted to give you a visual resource for how to tell a real N95 from a fake N95. This does not apply to KN95s. This image comes from the CDC website. And if you look at this illustration, you're looking for key information starting at the top, like the approval number, which always starts with the letters TC, and then the number 8, 4, and then the letter A. Next, if we move to the left, we want to see the brand name or some sort of a logo that's trademarked. Then we want to see the NIOSH name or NIOSH logo. At the bottom, we want to see the filter class. And for our purposes, we're looking at N95s, and N does not stand for NIOSH in this case. It stands for non-resistant to oil. So that's important to know. The lot number is nice to have. It's not always available and it's not recommended, but we do like to see the lot number. If not on the mask, we want to see it on the box somewhere. And then the model number. This information doesn't need to live in these locations on this mask that you see. This is just for illustrative purposes. But one thing to pay attention to in this diagram closely is the fact that this mask has head straps. If we go to the next slide, we'll see some other tips on how to identify fraudulent or counterfeit N95s. And you'll see things on there like, misspelling, or some of this information is not present. Any sort of add-ons to the mask of a decorative nature would indicate a red flag. Any claims to be approved for use in children would be a red flag. And then the bottom bullet point on that next slide is presence of ear loops. Any N95 that you see out there that has ear loops is clearly a counterfeit, because all N95s have head straps or headbands. So that's very important to know. If we go to the next slide, I want to talk a little bit about what to expect when inventory does become available. We have contracts directly with the manufacturers. We have calls with them weekly, sometimes more often. And they've all pretty much told us the same thing. Expect PPE to come back incrementally. As they are released from the Defense Production Act, they will start to get supplies back into the hands of the well-known supply companies that they have contracts directly with. And that's important to know, especially when we're all seeing offers that sound a little bit too good to be true, with people having access to large quantities of 3M masks, or any quantity of 3M masks for that matter, or large quantities of approved KN95s. If the products were that readily available, the large manufacturers or the more established supply companies or the larger supply companies would have them in stock. We would love nothing more than to be able to get you the PPE that you're looking for. So if we don't have them, if the Shines and the Pattersons and the Bencos and the larger companies don't have them, that's telling you something about the products that we're seeing available in the marketplace. I would also say be careful if you see any products that a supply company that you may have used before or have a relationship with start to offer new products that they haven't had in the past, specifically KN95s. Do your homework on those. And then expect some higher prices moving forward. We do know that certain companies like 3M have made commitments that once their products are available in the dental space, we'll see them return at close to the regular price they had before the pandemic, which is going to be fantastic when those do become available. For other companies, they're indicating with the high demand and short supply for a lot of the raw material prices have gone up. And a lot of the supplies that are making it into the United States are being flown in versus being shipped in containers. So flying products into the United States adds a lot of cost. In addition to higher prices to get things out of customs in certain countries, including China. We are seeing companies pay sometimes up to $200,000 to $250,000 to get their products moved up towards the front of the line in customs to try to get them out of the country. The last thing I want to share with you are a series of links, and these are resources that our team's using to vet through a lot of the leads that we get on a daily basis. So if you look at the CDC approved manufacturer list for N95s, there are over 280 approved N95 manufacturers on this site. It's important to know that most N95s have traditionally lived in the industrial channels and food prep channels, so they've not been a thing in dentistry. So a lot of the names that you see on there won't be familiar. And we've reached out to a lot of these companies to try to get in line to have contracts with them in order to get their products and make them available to you. The next one is the CDC counterfeit site. This is a great site to visit. The illustrations that I had on the previous slide came from here. They actually have photos of a lot of the counterfeit items that are in the market out there and give you additional tips on what to look for. So if you're seeing an offer or you have a mask in your possession, you're not sure if it's legitimacy, you can use this website as a resource as well. The FDA also has an emergency use authorization list for several categories of products. PPE obviously is one, but then also different devices. So you can see a list of those products here. And then one that I mentioned earlier, the FDA authorized N95 and KN95 manufacturers in China. This is the list that up until last week had about 60 different companies on it. But based on test results here in the United States, the FDA shortened this list down to 14. So a good resource to take a look at if, again, you purchased some KN95s that may have been on the list and you're not sure if they still are, or maybe they were not on the list at all. So with that, I will turn it over to Bill Sullivan once again.
Thanks, Mike. I just wanted to give you a quick update on where things are at in terms of the government and what they're able to supply for PPE. Basically, there's two sources we're looking at. The MDA was in touch with the governor's office several weeks ago regarding FEMA supplies, and dentists are in line to get that. But as Mike just said, there's for the FEMA supplies, the priorities are hospitals, nursing homes, and first responders. Right now, the amount of FEMA supplies that are coming into the state are just enough to cover those based on what we're hearing from the state. Once that supply picks up, then dentists will be in line to receive those FEMA supplies. There's another area, though, too, of government source of PPE, and that's from the Michigan State Police State Emergency Operations Center. The state of Michigan is also purchasing supplies that they can distribute as well. And their priority is first responders. Then they're going to be distributing it to others as well. And I know from talking to the people in the Emergency Operations Center just a few days ago, dentistry is going to be high on that list. And one of the reasons they mentioned for that is because they are remembering all of the donations that dentists made when this crisis first started. And so they want dentists to be able to get the supplies because they gave all theirs away to help with the hospitals and the nursing homes. Right now, with the State Emergency Operations Center, the MDA is working on donations of face shields and level 1 masks that are becoming available. And once that gets all worked out, the MDA will be in touch with local components. And the best way to keep up the speed on all this is watch for alerts from the MDA, and we will keep you updated on the PPE supply as far as the two government sources. So that was a quick update on that. And now I will turn it over to Dr. Deb Peters to discuss dental benefits.
Thank you, Bill. Good afternoon. For my comments today, I will highlight information under the broad category of dental benefits and address questions that the MDA frequently hears. Foremost on the minds of many dentists is the increased cost of providing dental care with the enhanced recommendations for PPE, changes to facilities, scheduling changes, etc. In the ADA statement on third-party payer reimbursement for costs associated, it included standards for PPE. And the ADA recommends utilization of the CDT code D1999, which is defined as an unspecified preventative procedure. As you know, when you enter a code that ends in 999, you need to enter something in the remarks section, and you can enter something like COVID PPE enhancements. Please refer to the updates on this topic on the ADA website, including how you may expect to see this code reimbursed by third-party payers. Secondly, the ADA is not aware if or how the use of this code may be benefited across a broad spread of payers, or what plan policies may be applied to impact frequency of use, allowable fee, co-payment, and balance billing. The ADA does update a list of third-party payers and their intentions at this time. And I noticed a question, so why are third-party payers involved at all? And keep in mind that this is primarily an issue in those situations where dentists have signed a participation agreement with a dental benefit company or a third-party payer. So please refer to the details of your plan. Which brings us to the question frequently posed about Delta Dental of Michigan and what can Michigan providers expect. A few weeks back, Delta sent a letter via email to its providers stating that neither D1999 or any other code would be considered as an appropriate code for PPE. Representatives from the MDA met with Delta Dental Michigan at the beginning of this week and asked the very question of, if not D1999, then what? How will Delta assist providers? Delta representatives state that they are sensitive to the financial hardship that the ongoing pandemic has placed on dental practices. Furthermore, it was confirmed that Delta of Michigan is exploring several options that may be acceptable to its providers. However, they gave no indication of appropriate measures or a timetable for this to occur. And when pressed on this matter, the answer was still the same. I'll briefly mention another strategy mentioned on the ADA site, which was to attempt to negotiate your participation contract with some of your plans. While this is not likely a quick solution, I wanted to bring it forward as something that may be worth your time to explore. And again, more information on the ADA website under that. The next aspect with dental benefits is to be aware of changes in a patient's dental benefit plan and to verify and retain records of eligibility. Again, guidance of appropriate exploration questions is on the ADA website. Keep in mind that often patients are not aware that their dental benefits have lapsed due to a layoff or a job loss due to COVID-19. And additionally, dental benefit plans may not have received timely notice of these changes by the employer, which could result in a takeback of the payment from future amounts owed to a provider. Without going into further details, just be aware of these issues and know strategies to ensure the success of your business office as you begin to submit more claims to third-party payers. And lastly, teledentistry came into this pandemic as a little known or utilized procedure for screening patients. The MDA addendum, areas on the MDA website, and the ADA site all list suggestions for using this method, along with which third-party payers are reimbursing for appropriate use of the code D0140. Both Blue Cross Blue Shield of Michigan and Delta Dental of Michigan have their teledentistry statements listed on the MDA website and linked through the addendum. So that is a very quick run through the 3 key principles to assist providers in the Department of Dental Benefits of PPE reimbursement strategies and a couple options, verification of benefit eligibility, and the utilization of teledentistry. Much more details can certainly be found by going out onto the ADA website and looking up their many sections under dental benefits. And now I would just like to pass it along to our President-elect, Dr. Steve Murrah, who will bring us up to date on moving forward. Dr. Murrah?
Thanks, Dr. Peters. And I was actually hoping that my slide would be a little bit blurry, so my picture looks a little more handsome, but there you go. But I'm glad to hear that we have more than anticipated participants, which is great. So basically, what are our next steps and where do we go from here? As you've heard, the MDA has been working every day, nonstop on behalf of Michigan dentists. 23 member alerts, almost 1 a day, in addition to 8 webinars to keep our members in the loop, multiple media spots weekly, persistent lobbying pressure on our Lansing policymakers. But some of you may say, well, that's great, but our offices are not yet fully reopened. We get that. Our end game is not recognition of these efforts, but to translate our message into our desired outcome. Well, what is our message? Michigan dentists have done their part to keep our community safe. We have done what we've been asked as far as keeping dental emergency patients out of hospital emergency rooms and keeping Michiganders home to help flatten the COVID-19 curve. We have developed a reopened dental offices work plan based on the latest safeguards and scientific evidence. We are ready, responsible, and prepared to reopen our offices now to help our communities that badly need our help with their oral health. Oral health is important, and many patients have conditions which have been getting worse. This does not mean that those dentists that do not feel ready will be mandated to reopen fully. We have also heard you. However, as a group, Michigan dentists are ready and can exercise professional judgment. Our good friends in other states have already started. I have personally spoken to dentist friends in Chicago and other parts of Illinois who just recently reopened. Their governor recognized their commitment and readiness. I think that the governor of Illinois did not make a mistake in this regard. Our plan is very similar to the dentists of the Illinois plan. We are also ready and will continue to be part of the solution. So going forward, what is our strategy? Have we been hiding the magic bullet strategy? I would like to thank those who thought that we have the power to snap our fingers and get anyone to do exactly what we want when we say it. It's flattering. I wish I had that superpower, especially being the father of 3 teenagers, believe me. But sadly, we do not have that superpower, so we must continue to work hard to make our case. And we will work hard, but just imagine how much more effective we would be to enlist the nearly 6,000 foot soldiers we have, the nearly 6,000 MDA member dentists to be an active part of our campaign. Wow, that would be helpful. My thanks to those taking the time to be on this town hall and those who participated in our call to action yesterday. Okay, back to strategy. What are we going to do and how will we get this done? All options are on the table. Let me repeat that. All options are on the table. We must continue to run a simultaneous, multifaceted strategic plan because likely it will be a combination of efforts to get things done. We will continue with aggressive lobbying, raising awareness among legislators and other stakeholders. You may have noticed that we joined forces with 21 other healthcare associations in our response to the governor yesterday, calling on her to let us reopen our dental offices now. We will enlist all of the help we can get. We will also continue to ramp up even more media and social media campaigns to support our message. Many of you may have been able to help with our social media blitz. Please remember that we are most effective when speaking with one message as not to confound or confuse what we're trying to do and why. When reopening is allowed or a date has been set, we will ramp up public education to reassure patients and encourage them to return to care. This has already been in the works. Again, our message is that we are ready and prepared and are part of the solution to keep people safe and healthy. Dentists have a strong track record of effective infection control. We take this seriously. We have our patients and our team's best interest at heart. We are part of the solution. Someone asked me the other day why the public awareness campaign wasn't going on weeks ago, and the answer is that we want to be most impactful, which is why this has been getting ready to launch when we get the go-ahead, as patients know that they can return for non-emergency care. We will push hard to get the message out to the public that it is safe to go to your dental appointment and the measures we have undertaken that they will see. All of us need to help in this regard. There is one person whose opinion counts the most right now, and that is our governor. We will continue to get our message heard and acted upon until this gets done. Thank you. Now I'll answer a few questions. I've actually been given 4 to start with before we turn over to the general Q&A. And as some may imagine, the first one is, if the governor does not reopen dentistry by the end of May, will the MDA consider suing? Well, first of all, we hope that this will be resolved by the end of May. We still have hope. As I said, all options are on the table. However, we would like to be effective quickly. We don't want to drag things out, nor would we certainly indulge everyone on legal strategy, which is not very strategic. Number 2, do you know if the stay-at-home order will be extended past May 28th? No, I do not know that. And again, we hope that it will not be, for us, will not be extended past the 28th, but that will be to be seen. Number 3, what will happen if there is another flare up in the fall? Well, I don't have a crystal ball, of course, but I think that we will hold true to those things that we know. Our science, our best practices, we have been learning as we go. I think we've been effective in flattening this curve. We have been active and helpful in treating our emergency patients, and we are active and responsible patients and what we have put forward as far as the Michigan addendum to the ADA toolkit. And number 4 question that I've been given, this is a little bit long one. I quote, I have heard rumors that some older dentists have decided to retire now due to the COVID-19 pandemic. In parentheses, I am 67 years old myself, but do not plan to retire. Since I anticipate not being able to see as many patients per day when we are allowed to reopen, I would think that this, combined with retirements, if the rumors are true, would create a severe shortage of capacity in dentistry. Any thoughts? Have you seen any evidence of dentists retiring earlier than they had planned to? Will there be a dentist shortage? Will practices shrink their size, and will costs for dentistry skyrocket? Well, that's a lot of questions, and I wish I had the answers to all that and more, but I understand what this dentist is asking. To be very transparent, we haven't seen that much yet as far as a bunch of retirements. I don't have any statistics in that department. This is something that we will continue to study. The ADA continues to study. We know that there have been a lot more dentists coming out of dental school in the last few years. We know that some of them have struggled for places to go. So we really don't know at this point what will happen as far as, will there be much more retirements? Will there be dentists around to treat patients? I think the short answer is we do have the capacity at this moment, but it's something that we'll have to see as things go. This is a fluid situation. And with that, I'd like to turn things over to Ms. Burgess for the general Q&A. Thank you.
Hi, everybody. This is Karen Burgess. I'm your executive director, and I've been taking notes while trying to manage the technology challenges about the incoming open questions. You know, we had many questions that relate specifically to PPE, and I'm hopeful that between Bill and Michael Wilgus that we covered quite a number of those. It's clear that this is going to be a challenge for many dentists, and that many have been preparing and feel prepared, but many others are not. Some of the other questions that came in, I have a couple here for Dr. Peters related to dental benefits companies. The question came in about a fee increase. Is there any opportunity for dentists to increase their fees if it's not allowable to do any kind of a PPE surcharge? So Dr. Peters, any comments on that question?
Sure, thank you. I'm assuming by the way that question was answered that they're referring to Delta when they say a PPE surcharge is not allowable, because keep in mind, in situations, you know, where you're not participating with any plan, a dentist has control of his or her fee schedule, raising their fees or instituting the utilization of the code that was recommended by the ADA. So I'm going to make that as an assumption, if I may, that, you know, so I'm basically looking at the question as, will Delta look at increasing all of our fees as an alternative to what is going on here? Again, when we asked at our meeting on Monday, and I was asked specifically what would be most appropriate, you know, in my head, in giving a higher reimbursement would greatly benefit all the dentists all the way across. And I don't think it's necessarily off the table, but I can't speak to what they're considering. They've got many moving parts. So I'm assuming that question was asked from that angle. If it wasn't, then please clarify and I can come back with more detail.
Thank you. No, I think that was what they were referring to. There was also a question for Dan Schulte, a legal question, and it has to do with the, there were actually two, and I'll give one first. The first one is, in anticipation of the governor allowing us to reopen dentistry, right now, my staff are not coming in because of the stay-at-home order. Can I have them come in to prepare, get the office ready, etc.? In other words, are they going to be violating the executive order to stay home if they come into the office to prepare for opening the office?
And I think the answer is no. I think that you can designate certain employees as essential employees for the purpose of making the necessary preparations to reopen your office in the near future.
Thank you. I appreciate that. And then the other question was, I have a colleague who says that he is simply going to pick a date and open. What is the risk to my friend if he does that?
Well, if the date chosen is earlier than when Executive Order 2020-17 is no longer effective, that person would be in violation of that executive order. which is a misdemeanor and potentially subjects that dentist to licensure sanctions.
Thank you. Another question that we had, I'm going to direct to Bill Sullivan. The question came in and said, how will the legislature's lawsuit, or should I say the legislators' lawsuit against Governor Whitmer proceed from a process standpoint?
So the way it would proceed from a process standpoint is right now it's in the Court of Claims, who I assume that whoever loses will appeal the case. It would then go to the Court of Appeals unless the Supreme Court took the case directly. But if the Supreme Court doesn't do that, it would go to the Court of Appeals, and then to the Supreme Court is where it would ultimately be decided.
And is there any kind of a time frame that you can anticipate, or is that completely unknown?
Unknown, I would think because of the gravity of the situation, it would move quickly, but I could not give you a timeline.
Okay, thank you. Here's a question for Dr. Vince Benavinia about testing. There was a question that came in that said, would it be appropriate and should we seek to have ourselves and our dental teams tested for antibodies to ensure that when we go back to work that we either are potentially immune or that we are at risk to get the COVID-19 in the office. Is that something that you had looked at or the task force had looked at, Dr. Benavinia?
Yes, that's a good question. I mean, you think about, well, why do they even have antibody tests? Well, antibody tests will tell you if you're positive to an antibody test, they'll tell you that, yeah, you were probably exposed to the virus, even if you were asymptomatic, and you developed antibodies to fight that virus, and now you have antibodies. But the problem is that nobody has shown, this virus is so new that nobody has shown or demonstrated that having antibodies gives you immunity to the virus. So theoretically, you may not be immune or you may be immune. Nobody knows. And then the question is if you have all of your office staff tested, and let's say maybe one person, one of your assistants comes back with a COVID positive antibody test. So now all of your other assistants are going to be looking at that assistant going like, oh, well, there's a risky patient here. Maybe you should treat that patient because you have positive antibodies and you're probably immune. Well, the problem is that we don't know if you're probably immune. You know, so at this point, we're not recommending that you have yourself as the owner of the practice or your assistants or anybody else in your office tested for antibodies. I think it would maybe give you a false sense of security if you came back positive at this point. Thank you.
Thank you, Dr. Benavinia. We've had several questions also about the PPP loan. You know, we are aware that many dentists have received PPP loans, and some of them have been able to defer taking to take the money. Others have had to take the money, of course, and there's a time period in which you have to begin to use the money for payroll. Correct? So the question that came in for Bill Sullivan on the legislative front is there any advocacy at the federal level, and what has the MDA been doing to try and get the length of time that dentists have to use that PPP money extended? With the offices being primarily closed to most business, it makes it difficult for them to qualify for having the loan payments forgiven. So, Bill, comment on that?
Yep, the American Dental Association is working on that issue at the federal level, and specifically in the next round of stimulus bills that pass, they are hoping to get addressed the issue of the 8 weeks that you have to operate under, and that extended to 16 weeks. So I do know the ADA has been actively working on that, and I would advise watching for announcements from the ADA regarding that issue.
Yes, we did do an action alert on that, did we not, to our members, Bill?
Yes, yep, about a week and a half ago.
To support that. And I did read on the internet today that the HEROES Act, which I believe includes that provision, was up for a vote in the House, but of course it requires the Senate as well. I have another question here that goes to Dan, and it relates to the legal issues associated with the judgment about what is emergency or or urgent versus non-emergency or care that should be delayed. One dentist wrote, for example, I work part-time as an FQHC dentist, and I was informed that I would be doing restorative work next week. If it is, is this something that could affect my license if I do what my employer requests?
Well, and I think the answer is yes. Your employer, or let me put it this way, the fact that your employer is requiring you to do something that violates Executive Order 2020-17 will not be a complete defense to you in a licensing action, or if you were charged with a misdemeanor. It would certainly be a factor in your favor if either of those cases were litigated, but it would not be a complete defense.
And if I could make a follow-up, restorative, we may be interpreting that to mean routine restorative, but if it has progressed to an urgent state or an emergency state, would that be a different situation in your opinion, Dan?
Absolutely it would, and it's in your professional judgment, the dentist's professional judgment, ultimately on a case-by-case basis, what is essential and not to be postponed.
Thank you. A question now for Dr. Peters that has to do with dental reimbursement. Wondering if you are aware, Dr. Peters, of any of the dental benefits companies being willing to extend the yearly benefit or even allow for more frequent pro fees, for example, for certain patients because there are patients who are currently delaying their care.
I'm not aware of any companies that are able to extend the benefit just because it involves win a clause. I will say it was a question that we did ask when we met in our Delta meeting, and being able to extend the benefit year was something that they clearly indicated that they would not be able to do. So if the plan was to expire June 30, it would not be able to be extended. As far as frequency limitations, that is something else we also discussed. And the comments back were there is going to be a little bit of latitude with some of the frequency limitations. For instance, as you know, depending on how plans read, if you had to push your patient back, so you're not seeing them at 6 months, and now you're seeing them, maybe it's a 10 months, so not quite 12 months, but you want, you know, there's some limitations there. That is something that they would take into consideration and perhaps extend some latitude. So my advice would be, because I can't speak to all dental benefit plans, I can't even speak for any of them, is certainly follow up with your local contact for that, whether that be, you know, one here in the state or elsewhere, or look at doing a pre-authorization on their website or their toolkit. But they are definitely things that we discuss, and it does seem to be moving in a positive direction in many of those situations.
Thank you, Dr. Peters. I have a question now for, I think it would be Dr. Smiley. Dr. Smiley, we do get a number of questions related to gowns and coverings. We had one of our participants today who has said, should I be having my patients wear a gown?
Okay, so when it comes to gowning, there's several things to take a look at. First of all, in the MDA addendum to the toolkit, you're going to find links to proper donning and doffing, that is putting on and taking off a gown. There's also references with the use of our gowns that they are to be used until basically, you know, they are soiled and need to be replaced. So the use of a gown, I wouldn't say that your patients need to wear a gown. Recall that the aerosol and the contamination that might be spread onto their clothing is their own. It's coming from them. I would recommend, however, that if a parent or guardian or other companion, support companion, accompanies the patient into the operatory, that you consider giving them a face shield as well as the wearing of their mask. You may even consider giving them a gown if they're going to be in the operatory, providing support for that patient or young child. But universally, no, I would not recommend a gown for companions that come to the appointment or for patients.
And if I could follow up, Dr. Smiley, we had several people who said they talked about the fact that even with pre-screening, as the ADA and the MDA is recommending, that you can never be sure that a patient is not COVID-19 positive. So should we not be treating every patient with the highest level of infection control and the highest level of PPE? I just wondered if you had a comment about that in particular.
I think that dentistry is very comfortable with the notion of standard precautions, as that's what came out of the era of bloodborne pathogens and the HIV crisis. Recognize that if you take a look at OSHA's recent Dentistry and Workers and Employers, Dentistry Workers and Employers guidance that they released a week or so ago, they talk about a difference between a known COVID patient and or a known or suspected COVID patient. And so there is a break in that. So yes, perhaps, you know, one could argue that all patients are potentially affected or infected, and we should all treat them the same. But there is a difference in that we are screening out those who are actively known infected and how those should be treated. And those are recommended by OSHA to be treated at a higher level than those who pass our screening test. So I'm not going to supersede OSHA in that guidance.
Thank you. Thank you, Dr. Smiley. So a question from Michael Wilgus, and I'm sorry, I don't remember if you addressed this, Michael, already. We're having a lot of questions about what is likely in terms of the timing for opening the supply chain, and if you have any recommendations for ways that the dentists can put themselves in a better position to buy the needed protective equipment. If you've already answered that, thank you. And if not, if you could make a comment, we'd appreciate it.
Yeah, no problem. I mean, I think it's going to be different by manufacturer in terms of when we see certain suppliers be able to get products into the dental supply space, depending on, you know, what their directives are under the Defense Protection Act. So that would be the first part of that answer. And, you know, with regards to some, I mean, we are seeing some movement, like I mentioned, in areas of face shields, hand sanitizers, you know, thermometers, although that's not the PPE that we wear. But it's gonna take some time. I mean, we've, in a direct conversation that we've had with 3M specifically, you know, they're not expecting to to be in a position to get appreciable quantities of PPE into the dental space probably for several months. And so, you know, that's coming from them. In terms of what we can do, I think, you know, to continue the collaborative efforts through the dental associations, you know, like I said, you've got suppliers getting involved in the lobbying efforts alongside the organized dentistry. You've got some manufacturers getting involved as well. I think, you know, we don't want to lose the momentum that we've started to gain. It hasn't gotten us the result that we want yet, but I don't think that this is a good time to take our foot off the gas. So, you know, getting all the members involved and getting everybody to push on that unified cause, I think, is our best bet. And then how FEMA might respond and how they choose to distribute dental supplies, if that's the direction they go, I think that remains to be seen. So we'll have to stay tuned for that.
Thank you very much. I have also had many questions, and we've answered quite a few of them. There's a couple hundred questions, and many of them are very detailed questions, but some of them go specifically to what is allowable today. And so, for example, I have had a question that said, please clarify about routine periodontal cleanings. I'd like to ask Steve Mara to answer this particular one. As a periodontist, I thought you would have some insight into this. She said the person said that they thought they understood that routine periodontal cleanings were necessary if it was necessary for the good health of the patient. On the other hand, routine periodontal cleanings with no particular emergency attached to them may not be appropriate under the current delay of any routine procedure. So Dr. Merrill, you want to make a comment on that?
Sure, thanks, Karen. And let me just say with my comment, I know one of my dental hygienist is on this town hall, so I've got to be careful. No, I'm kidding. But routine periodontal maintenance is very important. It is, you know, it's a great service and it's very necessary. However, as Mr. Schulte very succinctly mentioned earlier, it's not in the purview of our current emergency care. So while, you know, as I mentioned earlier with our strategic part, that, you know, there's a lot of care that needs to happen and certain conditions are getting worse. This much includes, you know, many of my periodontal patients and others alike. But we have to look at it strictly from the legal context with respect to emergency care.
Thank you. I appreciate that. We also had another question from a doctor who said that, you know, often many things such as deep caries that were not particularly symptomatic 9 or 10 weeks ago may, at this point, since it has gone on so long, be something that requires treatment, even if the patient is not currently having any symptoms to complain about. And he is asking, is that a correct interpretation or is that an incorrect interpretation? And so I'm going to ask one of the dentists to respond to that. Perhaps Dr. Merrill, would you mind taking this one also?
Wait, Karen, I'm sorry, Karen, could you just repeat the last part? You're talking about caries?
Yeah, there was the question is if my patient had deep caries 9 weeks ago and I delayed treatment, now it has gotten worse. Even if he is not complaining of pain, is this not something that, in my professional judgment, I could say requires treatment right now in order to avoid any further issues?
Sure, thank you for clarifying that. Well, I think it's similar to the last question in that it is definitely a needed service and something getting worse, but strictly from the context of, is it an emergency? related. If the patient is asymptomatic and not having, any appreciable consequences yet from this, it's certainly something that we want to address ASAP. But I think it goes back to, is it related to, within the context of emergency treatment? So if it's asymptomatic, well, I would, think we'd love to get in there and hopefully inhibit progression toward, further endodontic, problems, possibly. If it's asymptomatic and it doesn't seem emergent, I think it would be a similar example to the last question.
Okay, thank you very much. A follow-up question here related to dental benefits. Hang on one second while I find the question again. It has to do with, for Dr. Peters, are you aware, Dr. Peters, of any concern related to patients who may need care, but because of the very high unemployment rate, they may not have, they may have previously had dental benefits, but no longer have them. Would you like to comment on, is there anything that dentists should do to ensure that their patients do have dental benefits, or to discuss potential financing of what needs to be done with them in advance?
Sure, I kind of touched on that briefly in my brief comments. But yes, many patients may have lost their dental benefits, and some may have lost it and not be aware they lost. So it's highly recommended that you go through a series of exploratory questions. Has anything in your dental benefits changed? Has your job changed? So that you're kind of getting to the root of the issue. If they find that they don't have dental benefits, certainly there are many options that dentists can certainly have in their business model to help make dentistry affordable for the patient, and you can explore those. We have the program through the Michigan Dental Association of Care Credit, but I do think practitioners need to be aware of that. When you go back in and start treating more and more patients, some of your patients may have lost their dental benefits and not been aware of it, and likely some of the employers, there's a lag when they notify the dental benefit company, so they may come in for treatment and you may think they have it, and then they don't. So keep very close records of when, and verify eligibility every time. Screenshot that was another recommendation. If they have eligibility benefits, screenshot it so you have that and preserve that until you're paid. If a patient has lost their dental benefits, certainly that is up to you as the provider to assist them in any manner that you see. But unemployment as high as what it is, as well as the layoffs, which can affect all benefits, I think you should be wise to, ask the questions to go forward with a good business model and proceed from there with whatever plan. And when you bring your team back together, decide how are you going to respond to these patients when they've lost their benefits to help them with their dentistry. And that's certainly up to the individual office.
Thank you. Thank you, Dr. Peters. Here's one for Dan Schulte on the legal side. Dan, there's a question related to consent. So for example, and I believe that this may be covered in the toolkit, but just for the benefit of people who may not have read it, in terms of bringing back your staff, is it wise to have them sign some kind of consent or acknowledgement that they are working in a dental office which is not without risk and or completely free of risk? And what about a consent form or waiver for the patients? So any comments on consent and waivers?
Well, I think a consent or a notice form for both your employees and your patients is valuable, just so you can document the fact that you explained to everyone what the risks are of coming back to work or coming into the office to receive dental care if in the case of a patient. A waiver or a release I think those types of documents are going to be problematic for a number of reasons. It may not be enforceable as a condition of continued employment in the case of employees. And in the case of patients, among other reasons, if you are negligent in how you have prepared your office for a reopening, or in not using the right equipment or not taking the right precautions, whatever it is, a waiver of your own negligence is problematic. So I would advise against waivers and releases. I think they're more trouble than they are worth, but notices and consents are valuable in both the case of a patient and an employee.
Thank you, Dan, for that. And then just a question, I'd like to go back to Dr. Smiley. I know we're running out of time, so maybe this will be the last question, and then Dr. Gingrich can see if anybody has any last comments that they want to make from the panel. Dr. Smiley, there were a lot of questions that related specifically to how can I ensure that there is no transmission of aerosols from one patient to another, or from one patient to the next patient who comes into the operatory, or from for example, from one patient to another based on my gown or other factors. What other things should we be doing in terms of minimizing risk for aerosol contamination? Several people specifically cited studies that have talked about how long aerosol stays in the air and is, still active in terms of the virus. So long question, I apologize, but I'm kind of putting four or five different questions together.
Right. You prefaced it also by saying time is short, meaning, Chris, don't talk as long as you normally do.
No. Please give a thorough answer.
Yeah. So, yeah, some studies indicate that the viral cloud may remain within an operatory for up to 3 hours after an aerosol generating procedure. There are also some other studies that talk about how the virus is even present in the hallway in hospitals where COVID patients are being treated in a treatment room adjacent to that hallway. So those studies were out of Western China, I believe. That said, the transmission from patient to patient being exposed in an operatory after an aerosol generating procedure is really not something that is well documented. The fact that the viral cloud may have been there doesn't necessarily confirm that that viral cloud was infectious. To that end, what we can do, because we don't want to ignore that possibility, what we can do is we can look at room turnover rate. Now, your average dental operatory is maybe 7 by 10, or it is 10 by 10. So we can look at air turnover, how quickly we get the viral cloud out of the room. We can take a look at air filtration. We can take a look at negative pressure rooms. Have experience of those because when my wife was having her stem cell transplant for her leukemia, that was what she was kept in during the bone marrow transplant. A negative pressure room simply means that when you close the door, you have air that's actually being drawn in and shuttled out through the room. So all of these things are very possible. There's also the thing we showed, the suction units. Many of these things exist as strategies, but they are not within the ADA and the CDC guidance. And I think that that's something that you have to consider again, go to your best resources, use your best evidence before you decide to reach out and purchase something. Research it to see what the probability of infection or cross-contamination is. The greatest concern that is in the dental environment is contamination from patient to provider, because we work so close to that viral cloud coming out of the patient's mouth when we do aerosol generating procedures. The Department of Labor did classify oral health providers, and dentists are on there, but hygienists are even at greater risk, as are oral surgeons, because they're adjacent, close proximity, not socially distanced from that cloud that is being generated. So those are the greatest concerns. But, you know, relative to, you know, hard surface disinfection and so forth, we do these things. Asepsis, we do that. You can choose to change your gown after each use, but that guidance is not clear that it's mandated. It is more something that's recommended that you change your gown after use, and use is open-ended, meaning perhaps even after you have seen patients for that morning or afternoon, but definitely whenever it gets soiled. So I would say consult the best evidence. And for me, the best evidence is CDC, ADA guidance, OSHA, the people who are synthesizing the evidence out there and coming up with best practices for us.
Thank you so much, Dr. Smiley. Well, I see it is 3:57 and we are turning into a pumpkin. So I just wanted to let people know that we did get many, many, many questions. We will download those questions, compile them, and put together the answers to the questions that are a little bit more specific or things that we did not get to. If they are already answered elsewhere in the MDA resources, we will give you a link to that resource. So please know that we will, if we did not get to your question, that there will be a response provided to you. We just need you to give us a few days to get that done. Dr. Gingrich, I'll turn that back over to you.
Thank you, Karen. Once again, to remind everybody, due to the technical difficulties we had in the beginning of this presentation, we will be sending out the slides after this presentation. In closing, our MDA has been in existence since 1856. We have persevered through many challenges and are currently dealing with this pandemic. I believe MDA dentists are strong and resilient, and we will rise to meet the needs of our dental community in the current crisis. We are stronger together than we are apart, and I thank you for your loyalty and your continued support. Have a great day.